Hi, welcome to another video of Medic Notes. This video is on open appendicectomy. First, for preparation of the surgery. Wound infection is the most common complication following operation for acute appendicitis, so routinely give 500 mg of metronidazole and a broad-spectrum antibiotic, such as Augmentin, intravenously at induction of anesthesia. In patients with clinically severe acute appendicitis who are demonstrating signs of systemic sepsis, commence intravenous metronidazole and a broad-spectrum antibiotic as soon as the decision to operate is made. Patients who have a perforated appendix require a full 5-day course of broad-spectrum antibiotic and metronidazole. Next, to access appendix. As a routine, employ a Lanz incision in a skin crease. This modification of the gridiron incision transversely crosses McBurney's point, which is the junction of the middle and outer thirds of a line joining the anterior superior iliac spine and the umbilicus. The incision starts 2 cm below and medial to the right anterior superior iliac spine, and extends medially for 5 to 7 cm. It may be possible to site it lower in a young girl so that the scar lies below the waistline of a bikini. Alternatively, use the traditional gridiron incision, 5 to 8 cm long, in line with the external oblique fibers if you anticipate the need to extend the exposure. The incision crosses McBurney's point at right angles to the spino-umbilical line, 1/3 above, 2/3 below. If necessary, the external oblique muscle and aponeurosis can be split in both directions and the internal oblique and transversus muscles can be cut to convert the incision into a right-sided Rutherford-Morrison incision. If appendicitis is one of a number of likely diagnoses, opt for a lower midline incision. Next, opening the abdomen. Incise the skin cleanly with the belly of the knife. Divide the subcutaneous fat, scarpous fascia, and subjacent areolar tissue, to expose the glistening fibers of the external oblique aponeurosis. In the gridiron approach, these fibers run parallel to the skin incision. Second, stop the bleeding. Incise the external oblique aponeurosis in the line of its fibers. Start with a scalpel, then use the partly closed blades of Mayo's scissors while your assistant retracts the skin edges. Third, retract the external oblique aponeurosis to display the fibers of the internal oblique muscle, which run at right angles. Split internal oblique and transversus abdominis muscles, using Mayo's straight scissors. Open the blades in the line of the fibers and use both index fingers to widen the split. Provided the scissors are not thrust in violently, the transversalis fascia and peritoneum are pushed away unopened. Stop the bleeding. Have the muscles retracted firmly to display the fused transversalis fascia and peritoneum. Pick up a fold of peritoneum with tooth dissecting forceps and grasp the tented portion with artery forceps. Release the dissecting forceps and take a fresh grasp to ensure that only the peritoneum is held. Make a small incision through the peritoneum with a knife. Allow air to enter the peritoneal cavity, so that the viscera fall away. Use scissors to enlarge the hole in the line of the skin incision. Now protect the wound edges with swabs or skin towels. This picture shows how we split the muscles by using Mayo scissors. Split the opening in the line of the muscle's fibers to prevent muscle injury. Next, assess the intra-abdominal condition. Look, is there any free fluid or pus? If so, take a specimen for microscopy and culture. Find the cecum, identify a tinea and follow it distally to the appendix. Insert a finger and lift out the appendix by pushing from within, not by pulling from without. If the appendix is not evident, push your index finger posteriorly until it comes to lie on the peritoneum over the psoas muscle. Then, maintaining contact with the posterior peritoneum, draw your finger to the right until it can go no further. The cecum should now lie between the hook of your finger and the right limit of the iliac fossa, and may be gently pushed out onto the surface. In some cases you may need to mobilize the cecum by incising the parietal peritoneum in the pericolic gutter, in order to raise the cecum on its mesentery, especially if the appendix is adherent retrocecally. If the cecum is not evident, remember that it sometimes lies quite high, under the right lobe of the liver. Confirm the diagnosis by looking at the appendix, or more usually its tip, is swollen, congested, inflamed, even gangrenous, often with fibrin deposition, turbid fluid or frank pus. After confirming acute appendicitis, mobilize the appendix from base to tip by gently moving or peeling away adherent structures. Remember that the artery enters from the medial aspect. If the tip is adherent, improve the view. Do not dissect blindly. If necessary, extend the incision. Apply Babcock's tissue forceps to enclose, but not grasp, an uninflamed portion of the appendix, to hold it so you can view the mesentery against the light and identify the artery. Pass one blade of the artery forceps through the mesoappendix and clamp the vessels. If it is thickened, take the mesoappendix in 2 bites. Divide the mesoappendix distal to the clamp and ligate the vessel gently but firmly with 2-all vicryl or similar material, ignoring the slight back bleeding from the distal cut end. Crush the base of the appendix with a hemostat, then replace the clamp 0.5 cm distal to the crushed segment. Ligate the crushed segment with 2-all vicryl. Apply a hemostat to the ligature ends after trimming them. Cut off the appendix just distal to the hemostat. There is no need to invaginate the appendix stump by use of a purse string suture, nor should the appendix stump be diathermized. For closure of wound, pick up the edges of the peritoneum around the entire incision with fine hemostats to allow easy and safe suturing of the opening with continuous 2-all vicryl or similar material. Insert interrupted stitches of the same material into the internal oblique muscle with just enough tension to oppose but not strangulate the muscle fibers. Now close the external oblique aponeurosis with a continuous vicryl stitch. Apply povidone iodine solution to the wound once the peritoneum is closed. Oppose the subcuticular tissues with fine sutures in an obese patient and close the skin with a continuous absorbable subcuticular suture or clips. For post-op, in the absence of general peritonitis, start oral fluids and a light diet as tolerated when the patient is fully awake. If the appendix was perforated, and particularly in a high-risk patient, continue antibiotics for 5 days. These should be given intravenously until gut function returns. Remove any drain after 2 to 3 days unless there is still profuse discharge. Monitor the wound if pyrexia develops, and exclude chest and urinary infection. There are some possible complications of open appendicectomy. Wound infection develops occasionally in patients with mild appendicitis but has a higher incidence in those who have had a gangrenous or perforated appendix removed. Anaerobic Bacteroides and aerobic coliform organisms are usually responsible. Examine the wound regularly and remove some of the skin suture or clips if there is evidence of infection, to allow any pus to drain. Check the results of any microbiological investigations taken at the time of surgery and tailor antibiotic therapy accordingly. If pyrexia develops, always carry out a rectal examination. Pelvic infection produces localized heat, bogginess, and tenderness. Repeat the examination at intervals to detect if an abscess develops and points. Be willing to aspirate it using a needle inserted through the vagina or rectum. If needle aspiration confirms the presence of an abscess, gently thrust closed, long-handled forceps into the cavity to drain it into the rectum. Ultrasound or radiological imaging may help if you are uncertain and may allow percutaneous drainage of a collection. Reactive hemorrhage is infrequent, but occasionally the ligature falls off the appendicular artery. Return the patient to the operating theater and reopen the wound to catch and religate the artery. Lastly, fecal fistula develops in 2 circumstances. Either the patient has unsuspected Crohn's disease or in florid appendicitis the appendicular stump or adjacent cecum has undergone necrosis. In the presence of necrosis, do not over-optimistically rely on suturing the defect. Prefer to insert a large tube in the hole and suture the margins of the hole to the anterior abdominal wall where the tube emerges. The tube can be removed after 2 weeks and the fistula will heal spontaneously. That's all for this video. Thank you.